Okay, we're going to examine the chest, listening to the heart, listening to the lungs. And the most important aspect of that examination is what you hear with the stethoscope. Everything's important, but the most important part is the auscultation. So let me say a few words about a stethoscope. You want to make sure you have a good one. A good one costs about $75. There are cheaper ones out there, but I don't recommend that you waste your valuable time trying to listen with one cheaper one. You can also spend hundreds of dollars to get a cardiologist stethoscope. You don't need that either, but you need a good quality middle ground stethoscope. Also, the length of the tubing is important. This is a borrowed stethoscope. It's a little bit longer than I prefer. This is 24 inches long, and they have them that are 2.5 or 3 feet long. That's definitely too long because that attenuates the sound so that you can't hear it properly. I prefer an 18-inch stethoscope, 18-inch tube, so that you can hear the sounds the best. But this is all right. Anything shorter than 18 inches is too short. So that's what I suggest. And make sure when you put the stethoscope on that the earpieces are angulated forward. It seems silly to mention that, but I do see a lot of people put them on backwards. And you should realize that they have to be angulated forward. That's the way the ear canals go. Also make sure that if you're listening with the diaphragm, that it's hooked and twisted so that the diaphragm is open. And you can determine that by twisting it, and you can see where the little hole that connects to the diaphragm and the bell is open or closed, and you get skilled at doing that. The diaphragm is used for most listening. It picks up a wide frequency of sounds, particularly high sounds. You press it rather firmly to get the best effect. The bell is for low frequency sounds, particularly listening to the heart or taking blood pressure. You use the bell rather than the diaphragm. And you twist it to the bell side, and you just obtain a very light skin seal, but it has to be a complete skin seal to be able to hear those sounds properly. So let's go ahead with the examination. You can put this on your neck for now. And we're looking at the person's chest, and we're looking in this case at Honora, and to see whether she's breathing normally. There should be very little effort in normal breathing. If the person is making an effort, that's abnormal. Either they've been exercising or they've got lung problems or chest wall problems. So when they're a little bit nervous, certainly they may pick up a little bit more effort when they're breathing. But ordinarily when we breathe, it's very efficient, and we breathe very quietly. We also look for retraction. We do these examinations in Western medicine with the person wearing a gown, completely unclothed underneath the gown with all underwear removed. And then we properly drape the person to protect their modesty. And then we can look at areas that we want to see the best. But particularly in children, when you're examining their chest, look for retraction of the intercostal cartilages. Because if there's a problem with the lung compliance, as in pulmonary fibrosis or in respiratory problems in children, like the croup, for example, there will be a retraction when the baby breathes and the child breathes. Those intercostal spaces will suck in rather than expanding out with the rest of the chest, because the lung's it's fighting you, it doesn't have enough compliance. So it's pulling in. So you're looking for retraction, and you're looking for normal respiratory excursion. The diaphragm seems to be pulling down and opening the lungs like a bellows. And then we look for landmarks. We have many landmarks on the chest, and we first look at the sternal notch, and we see the 3 parts of the sternum: the manubrium, the body of the sternum, and then the xiphoid process, which is further down. And we'll have a better look at that later on when we're examining her when she's supine. About 5 centimeters down from the sternal notch is the angle of Lewis, where the manubrium meets the body of the sternum. And that sticks out as a ridge. I think you can see it. She has a prominent one. Honora is a perfect patient. And right opposite that sternal angle there, or the angle of Lewis, is the second rib. And it's just underneath the second rib that you listen to the aortic valve on this side and the pulmonary valve on that side. So those little spots there are very important, and they're right at the angle of Lewis. Then we look at the clavicle, and we can see that the clavicle inserts onto the sternum here, and it inserts out onto the coracoid process out here. And if we want to know exactly where it inserts, we have the patient move her arm forward and backwards, and as she moves her arm forward and backwards, you can feel the articulation of the clavicle with the acromial process of the shoulder here. So we want to determine the mid-clavicular line. The mid-clavicular line on both sides is an important landmark. The mid-sternal line is the first landmark. The mid-clavicular line is the second landmark. Then we have three landmarks that have to do with the axilla. With the person's arm raised, the anterior axillary line runs all the way down to the abdomen, the mid-axillary line, and the posterior axillary line. So we refer to those in our examinations. So those are the main landmarks in front. Now, if you could turn sideways a little bit, yes, just put your legs up in the yoga position. Now let's move your hair off to the side here. We look at the landmarks in the vertebra. When you bend forward slightly, we can see the cervical vertebra. And the most prominent one that really sticks out is C7. Usually C7. This is probably C7 here. And then the first thoracic vertebra is T1. That's right also underneath it and sticks out quite a bit. So C7 and T1 are here. They're easy to see in most people. And then you can count down from there so that you know where the ribs are that come off those particular vertebral bodies all the way down the back. Now you can put your head back up straight again. And then you see the scapulas. And the scapula is about 5 or 6 centimeters out from the midline of the vertebral bodies posteriorly. And it's in that area that we hear the lung sounds the best because we're not hearing them through the shoulder bones. And also where we percuss the best when we're percussing lung sounds, and I'll talk about that in a minute. So we do percuss up and down the line just inside the scapula on both sides, and then we percuss laterally once or twice as well. And then, so we're inspecting the chest, and now we're going to go ahead and do the palpation part of this. So let's turn around the other way. Also, let me just say that when we're listening anteriorly, we listen in the mid-clavicular line, or just inside the mid-clavicular line, in 5 different places up and down the chest, moving the breast out of the way as necessary, and then 2 places laterally under the scapula in the back, and laterally in the rib cage here for the middle lobe. So we're listening to 7 different places, 1, 2, 3, 4, 5, 6, 7 on each side, front and back, or 6. But you want to be systematic however you do it. Some people just listen to 4 places here and then on down. But 4 or 5 is appropriate depending on the size of the person. So we've inspected the chest now, and we can see that her chest is perfectly normal. So we have the 4 modalities of the Western examination: inspection, palpation, percussion, and auscultation. So let's do palpation now. And what I'm going to do is put my hands on the sides of her chest from the back and feel her respiratory excursion while she's breathing normally. You should be able to feel that move 3 or 4 centimeters as she's breathing. And if you're not sure about it, turn sideways again so we can see the back, if you will. What you can do is you can put your hands in the lower part of the chest, and your thumbs move just a little bit more around if you can. That's good. Perfect. Perfect. And you can put your thumbs like this, and then see what happens when she breathes. And you should see an excursion of 2 or 3 centimeters. If it's much wider than that, it suggests that she's struggling with her breath and she may have COPD, or she may have asthma. She's breathing much more rapidly and you can see a wider excursion. Now we're going to check for fremitus. Fremitus is the vibration of the voice when the person says 99. So you can go back the other way. That's perfect. Thank you.
Sideways?
Yeah, no, just sitting normally in front. Thank you. So we'll have her say 99, and we'll feel over the back in 2 or 3 places inside the scapula. You can imagine me doing that. And also in the front here. Put both hands on the chest and ask the person to say 99. Okay, Hanara, say 99.
99, 99, 99, 99.
Now, ordinarily you hear that as
Was there
and
a
you
Beatles
feel
song
it
when you
as a
said
very
99?
slight buzz. Pardon me?
There was a Beatles song that I'm remembering. It's okay.
Oh, I think so, yeah. Say it one more time.
99.
You definitely feel with your hands, your thumbs, and your whole hands that vibration. It's very, very soft. If the person has a pleural effusion or a pneumothorax, you won't feel anything. And if they have consolidation, as in pneumonia or heart failure, the lungs act like a megaphone and they magnify the sounds and the vibration. So you'll feel it much more prominently. And you'll feel a real buzz in your hands when she says 99. You'll just feel that buzz. And so that's called fremitus. Sometimes they refer to it as tactile fremitus. That's the way I learned it. But the word tactile is obviously redundant because you're feeling it tactile with your hands, or you're feeling fremitus. So we've finished the palpation now. Now we'll do the percussion. And when we do percussion, we use both hands, of course, and we tap with our right hand onto the middle finger of our left hand. I'll just demonstrate how we do it right here. And what I do is I stabilize my hand with my thumb. So I tap like this. And I lift my hand off after I tap, because I'm sort of dampening the sound I hear if I keep my hand on there. And we're listening for a drum-like sound. We actually, when we tap, we use the right hand tapping on the left hand. We're all trained to do it that way. Left-handed people who are more dexterous with their left hand can do it this way, but I strongly do not recommend that. I happen to be left-handed. And I'm very strongly left-handed, left-eyed and left-footed, but I do things with my right hand that I'm taught to do in Western medicine. And there are 5 different qualities of sounds that you can hear. The softest is flatness. And flatness you hear or kind of feel when you percuss the thigh. You can hear that if you practice it. It's just totally flat, but it's a sound, you can hear it.
Is that because there's nothing hollow in there?
Right, and it's a very soft, giving structure. Mm-hmm. So you can't create any drum-like vibration at all. Mm-hmm. Totally flat. The second level is dullness, and you get dullness when you percuss over the liver. And it's a slightly more drum-like, but still pretty flat. Can you tell the difference? Mm-hmm. Very definite difference. So this is flatness. No sound. You can hear the sound of my fingers, but nothing drum-like underneath it at all. Dullness is the second one, is slightly drum-like, but not much. Mm-hmm. Then the third sound is resonance. And resonance is what we hear over normal lung tissue because the lungs are filled with air. Listen to this. Hear the difference? Compared to this. Or this. So this is resonance. Now, if the person has increased air in their lungs because of emphysema, or because they've got a collapsed lung that's full of air, particularly with the tension pneumothorax, then you hear hyperresonance. That's the fourth. And the fifth is tympanitic, or it's sounding like a timpani in the symphony. Boom, 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 boom. You hear that over the gastric bubble, or in some cases of a tension pneumothorax. So we're going to percuss in these areas that I've talked about, from one side to the other. Watch how I do it. And we can do it through her clothing. It's ideally best if the patient's bare and draped. Now let's do it over the back. Turn just a little bit. And let's pull your hair to the side. It works even better over the back. You stay inside the scapula, and you can listen to it. I don't know how well you can hear with this recording, but when you practice it, you'll hear it well. Hear that resonance? Mm-hmm. And then laterally, under the scapula, Now the lungs are higher in the chest than you think. The lowest extent of the lungs posteriorly is the 10th thoracic vertebra and the 10th rib. And anteriorly, turn around the other way if you will, the lung extends down just to the 6th rib anteriorly, going down to the 8th rib in the anterior axillary line. So the lungs are higher than you think they are. They also extend up above the clavicle, 2 to 4 centimeters on the medial side here. So that's a very dangerous area to needle, particularly if you're doing facial rejuvenation acupuncture. Those areas are often needled, and they're done very skillfully and obliquely so as not to cause a pneumothorax.
Is it the same one side to the other?
Yeah. And it doesn't extend out this far here, but the lung in this part here rises about that high above the clavicle. Wow. So we've percussed now, we've palpated, and we've inspected, and now we're going to listen with a stethoscope. This is the most important part. So you have the person breathe with their mouth open and breathe deeply. Now normal lung sounds are what we call vesicular sounds. And what you hear with the vesicular sound is you hear all of the inspiration and the first third of the expiration. You hear a continuous sound, and I'm going to imitate it for you now. You don't hear the rest of my expiration. You hear the first third of it. But it's continuous. There's no gap. Listen. You're always hearing something. That's vesicular breath sounds. The second kind of breath sounds are bronchial breath sounds. And those are abnormal. They're heard over areas of pneumonia or heart failure. Sometimes we hear them over the manubrium, where the trachea is. And we hear all of expiration, and we hear a higher pitched, louder sound, but there's a gap between inspiration and expiration that we don't have normally. So it sounds like this. With a gap between. Then we have a third kind of breath sound, and it's a judgment call, which is halfway between the two, bronchovesicular breath sounds. The normal breath sounds are either vesicular or in some areas on the inside of the first and second ribs, bronchovesicular breath sounds, but not bronchial breath sounds. Those suggest pneumonia or heart failure. So breathe in deeply with your mouth open, in and out. The same way as we did the front, over the same areas where we percussed with the diaphragm. So are you ready to breathe 14 more times?
Sure.
Okay, there we go. Okay, now breathe in and out. And twice more. Perfect, perfectly normal. Normal vesicular breath sounds. Let me also say to you that the place where you'll hear the breath sounds the best in the entire chest is right here in the mid-back area inside the scapula. In these areas here, you hear the breath sounds the best of anywhere. So if you want to zero in and start out with the back examination and then do the front later, that makes a lot of sense. So in Honora's case, we're listening to her lungs. We've heard vesicular breath sounds everywhere. Slightly bronchovesicular over this area here where we have the major air passages going into the lungs. But otherwise, everywhere, vesicular breath sounds. And those are perfectly normal. Now, if she had heart failure or pneumonia, we might hear crackles. We used to call them rowels. We even use the French term that has a circumflex accent over the A. Rowels are the same as crackles. And they sound a little bit like Velcro unfastening. Before we had Velcro, we used to say that they sounded like a Christmas tree burning by the side of the road after Christmas. They sound a little bit like that. And they're inspiratory breath sounds, and we hear this fine crackles. That suggests that there's fluid in the alveolar sacs, either heart failure, fluid, venous congestion, or serous fluid and pus in the case of pneumonia. So when you hear crackles in the lungs, that's abnormal. We also hear other sounds called rhonchi, which are mucus secretions in the air passages, and those clear with coughing. So whenever you hear any of these abnormal sounds like crackles or rhonchi, ask the person to cover their mouth and cough, or cough into a piece of Kleenex. If those go away or improve, that suggests that they're rhonchi, seen with bronchitis, with smokers, with emphysema or chronic obstructive pulmonary disease, and also seen to some extent in pulmonary fibrosis. So these are the abnormal breath sounds that we listen for. Rhonchi, crackles, and then if a person is asthmatic, we hear wheezes, which is an expiratory sound, and it sounds a little bit like this. With an accentuation of the expiration. We don't just hear the first third of expiration, we hear all of expiration when there's a wheeze, when the person has asthma. And in children, we sometimes have acute tracheitis, where we have an inspiratory wheeze. We call that a stridor, S-T-R-I-D-O-R. And we have an inspiratory sound. Sounds like the honking of Canadian geese, kind of like this. Like that. So it's an inspiratory sound. And the expiratory sounds, I know I look and sound ridiculous, but I'm trying to.
No, we've all heard these if we have kids.
Yeah, we have. So stridor is an inspiratory sound, and wheezing is an expiratory sound heard in asthma. So now we're going to examine the heart. So why don't you lie down and with your head in that direction. And you might need something for your head to make it more comfortable.
I think I'm probably okay.
Are you okay?
Wait a minute, time out. Does he want to be in close
I think
for where
so,
you're
yeah.
putting the, yeah, let's
So,
do
and
it.
in fact, can you undo the straps or the heart exam? We're going to do the heart examination now, and we already identified the landmarks of the chest in terms of the heart, the sternal notch, the manubrium, the angle of Lewis, about 4 to 5 centimeters down, and you'll feel that as a prominent ridge, more prominent in some people than others, but it's always there. Right opposite that is the second rib. The first rib runs under the clavicle, as you remember, and then underneath that is the second interspace where we listen to the aortic valve on the patient's right, but on your left, and the pulmonic valve on your right. And so then down the sternum, in the fourth interspace, you can count down, feeling these against the sternum. The fourth to fifth interspace is the tricuspid valve, just lateral to the sternal border. And then out in the midclavicular line, in the fourth to fifth interspace, we listen for the mitral valve using the bell. And so we're identifying those landmarks. Let me lift up just a little bit here to show the other landmarks of the chest. The costal flare. As you know, the first 7 ribs attach to the sternum, and the other ribs do not. 8, 9, and 10 attach to each other in this costal flare, which is like an inverted V. And the 9th and 10th ribs attach down at the bottom of this little mass of cartilage here. And the 11th and 12th ribs are floating. And you can feel the 11th rib anteriorly, and quite often you feel the 12th rib posteriorly, and those ribs are floating. So we have the costal flare here, and we can count down. We usually just count down about 4 or 5 interspaces for listening to the heart. So we're now going to, we don't palpate or percuss the heart, we just listen to it. But we do palpate one thing, and that is the point of maximum impulse, or the PMI of the heart, out in the 4th or 5th interspace. And in a woman, we often do that under the breast. So I'm going to listen here. I'm going to lift up here, excuse me, just a little bit. The 4th interspace. And in a lot of people, it's difficult to feel the cardiac impulse, or the point of maximum impulse. But it's always good to try to feel it. If you can't feel it when the person's supine, ask them to turn halfway to the left. That's called the left lateral decubitus position. So that you can put your arms down and just rotate slightly to the left.
I've got this machine attached to me.
Right. Rotate slightly. That's perfect. Now in that area, that increases your ability to feel the point of a maximum impulse. And I can feel it there. If you can't feel it, that's just fine. Sometimes a person's chest wall is too thick, or the muscles are too thick, or there's too much fat, or they have a barrel chest and you can't feel it. But what is of greater interest medically or concern is if it's very strong and powerful, because when a person goes into heart failure, this becomes booming. And when a person has an enlarged heart from high blood pressure, or from a valvular disease like aortic insufficiency, aortic regurgitation, the heart becomes huge, and this is just pounding in the chest, and you can feel it here as a very, very powerful beat. So that's the only palpation that we really do, and then the rest of it is auscultation, and that becomes very important. So we're going to listen over the aortic valve, and it has to be in a very quiet room with the diaphragm. Here we go. When you do this, ask the patient to expire and hold their breath after they've breathed out, because that brings the chest down and the heart closest to the chest wall, quiets the chest so that you can hear it well. So take a deep breath in, and then breathe out, and then hold it. Now breathe. You can't let them go on too long that way. So you're listening to the heart, and you've got to really train your ear. You hear the lub-dup of the heart. And it may be faster than that. It may be lub-dup, 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 lub-dup. But that's what it sounds like, is lub-dup. The lub is the closure of the mitral valve and the tricuspid valve underneath it. And the dup is the closure of the aortic valve and the pulmonary valve underneath it. And it's a snapping sound because the pressure is high in the aorta, and it presses that valve and snaps it shut after systole. And the mitral valve is a softer, duller sound. So you hear lub-dup, 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 and it may be faster than that. Lub-dup, 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 lub-dup. And you have to separate the lub and the dup. And during that lub-dup interval is systole, when the heart is ejecting blood into the aorta and into the pulmonary arteries. And in between the lub-dup and the next lub is diastole, when the heart is filling and resting a little bit before it ejects the blood. So we have to separate those in our minds when we're listening to the heart sounds. If you listen carefully, you can also hear in most patients both the aortic and the pulmonary valve. And you hear the aortic and pulmonary valve split when the person takes a deep breath in. That fills the chest with negative pressure, fills the heart with blood, sucks it full, and then the heart has to work harder to eject all that blood into the, on the right side where it's all coming in, out into the lungs. So it takes a little bit longer for the right side to empty. So you hear lubbed it up, lubbed it up, lubbed it up. And the second da-up is the pulmonic valve closing, if that makes sense. So here we go. We're going to listen again, and we're going to see if we can hear this split. Right there. Now, take a deep breath in and then breathe out and hold it. Now take a deep breath in and hold it. Yep, I can hear that. Now breathe normally. Now we'll listen on the pulmonic side, which is right there. Now take a deep breath in and breathe it out and hold it. Now take a deep breath in and hold it. Yep.
Are there places that people can get CDs or
Yes,
websites where
yes.
they can hear these sounds?
Yes, thank you. You're listening to me describe it, and it's best for you to go online, or you can get through Amazon.com. You can find books on cardiology and on physical diagnosis that have CDs of these heart sounds, and you can listen to all these heart sounds yourself. And you'll also hear the sounds of the murmurs. But I'm going to describe those to you. But let's listen to the normal valves first. I'm going to listen to the tricuspid valve now. On the left sternal border in the 4th to 5th interspace. Honor is an ideal patient in every way, and in this particular regard, she has a very slow heart because she's athletic and healthy, so you can hear lubbed up, lubbed up, lubbed up very, very distinctly and clearly. And she has a thin chest. And so now I'm going to listen for the mitral valve, and I'm going to put it into the bell mode and listen in the 5th interspace. And the midclavicular line right there. You can work around a patient's clothing just fine. That's great. Okay. If you can't hear it well there, which I can hear it perfectly clearly, again, you can have the patient turn into that halfway left-sided, we call it the left lateral decubitus position, meaning halfway over, and you can hear it. And it sounds more like lubbed, lubbed, because you're hearing the lub as the mitral valve. Rather than lubbed up, you're hearing lubbed up, lubbed up, lubbed up. So then, if you're listening to murmurs, you listen in these same areas, and there are 4 prominent murmurs that we talk about in the book that are the most common. There are other murmurs, but they're much less common. But if you listen to enough hearts, you will hear these murmurs. Quite often the person knows they have a murmur and they'll tell you, and that helps you, and then you can listen for that murmur. But what's particularly exciting for you as a professional is if the person has the murmur and they didn't know about it, and you pick it up and you hear it, and then you refer them to a cardiologist. It's exciting, since they already had it, that you discover that. And you say, by the way, this person's got what I think is aortic stenosis. So there are 2 kinds of murmurs. There are the innocent murmurs, which are not harmful. We call them innocent because they don't do any harm. And there are the pathologic murmurs, which damage the heart and affect the health over time. Innocent murmurs are very common in childhood, where children have very powerful hearts that beat more actively than adults. And they're also common in athletic individuals who have developed their cardiac reserve, and so that you hear these murmurs. And you also hear them in hyperdynamic conditions in adults, such as hyperthyroidism, or prolonged fever, or pregnancy, where the heart is working extra hard. These murmurs are in the middle of systole. They're always systolic murmurs, and they sound like this: lub-shtup, lub-shtup, lub-shtup. And you hear, if you listen carefully, that there's an interval, lub-shtup. The pathologic murmurs are different, and the most common is aortic stenosis, very common in older people. If you listen to enough people of 65, 70, 75, 80, you'll hear aortic stenosis that hasn't been diagnosed before, I dare say, because it's so common. When that aortic valve gets very tired, after beating millions and billions of times, it becomes calcified and it causes a narrowing, and this person gets aortic stenosis. And that's a diamond-shaped murmur that goes from systole to diastole, and it sounds like this: la-zh-dup, la-zh-dup, la-zh-dup. And you hear it best over the aortic valve. Pulmonic stenosis you hear best over the pulmonary valve. The second most common murmur, that's also systolic, is a mitral murmur, and it's a murmur of mitral regurgitation, or mitral backflow, where the mitral valve is weakened. That happens where the papillary muscles prolapse. It's also a side effect of many diet pills in the past. People get mitral insufficiency from taking fen-phen, for example, for weight loss. The mitral insufficiency, the second most common murmur, is also systolic. And you don't hear the lub because the mitral valve is damaged. You just hear this systolic murmur as the blood is being forced back through the mitral valve when the ventricles contract. And it sounds like this: zdup, 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 zdup. You don't hear the lub.
So I know you've done it before, but can you show us one more time exactly where you would listen for each of those murmurs?
Yes. So you'd hear aortic stenosis over the aortic valve in the second interspace on your left, the patient's right. We usually talk in terms of the patient, right there. You'd hear pulmonary stenosis over the pulmonary valve, exactly opposite side of the sternum, on the patient's left. You'd hear tricuspid regurgitation, which is a systolic murmur and is very rare, over the tricuspid valve along the left sternal border in the fourth interspace. And you'd hear the second most common murmur, which is mitral regurgitation, in the fourth or fifth interspace in the midclavicular line, right under the breast in a woman. And you'd hear it, and it would sound zdup, like that. Then we have two diastolic murmurs. Diastolic murmurs are always abnormal and should always cause your attention and need to be referred to a cardiologist. And the two most common are aortic regurgitation, once again heard over the aortic valve, in early diastole. And it sounds like this: it's the blood flowing backwards after the systolic contraction. It sounds like lub-dup, 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 as it's leaking back from the aortic valve. Or the pulmonary valve, it would be the same, heard in the area where that valve is best heard, second interspace. The fourth most common murmur, which is not common anymore since we discovered penicillin, is mitral stenosis, because it was a very common murmur seen with rheumatic heart disease following a strep throat. But now that penicillin has eliminated most strep throats, we don't see it as commonly, but we still do encounter it. And mitral stenosis is a pre-systolic murmur, just before systole, as the blood is being forced through the mitral valve, and the mitral valve is stenotic and resisting that. So it's a presystolic murmur, also in diastole, and it sounds like this. Shlubbed up, shlubbed up, shlubbed up, shlubbed up. That's mitral stenosis, heard best in this area over here.